Hello, everyone, and welcome. Thank you so much for joining us today. I'm very excited today to be presenting you all with the Autism Intervention Research Network on Physical Health LEND seminar series. And today we'll be specifically focusing on neurology, or the neurology node of the ARRB. I'll go ahead and introduce myself first, as will other colleagues who are a part of this presentation today, and then we'll move into speaking a little bit more about ARRB and the neurology node. My name is Rujitha Wilson. I am a woman, brown woman with long black hair. I'm sitting at a desk, and behind me is a table with 2 chairs. I am an assistant professor at the UCLA David Geffen School of Medicine in both neurology and psychiatry. I'm also the Autism Intervention Research Network on Physical Health Neurology Node Director, and I'm also faculty on our UC LEND here.
Hi, everybody. I am Gary Stobie, and I am a white male sitting at my home office right now. I am happy to be here today. I am a clinical professor at the University of Washington in neurology and psychiatry, and I am medical director of our adult autism clinic at UW, and I'm also the lead of the CRE at the University of Washington as part of the ARRB. Thank you.
And hi, everyone. My name is Andrea Ordia Dasher. I work with the CRE, Albert Einstein College of Medicine. Today, I'm playing more of a background coordinator role, facilitating this discussion. And I am a white woman with long brown hair that I have in a ponytail. I am in a green top sitting in front of a Zoom background that is white with our center's logo on it. Ooh, wrong side. The Children's Evaluation and Rehabilitation Center. Thank you. I'm excited to be a part of this.
Hi, everyone. My name is Zach Williams, and I am a 6th-year MD PhD candidate at Vanderbilt University, as well as an autistic self-advocate and a member of ARRB's Autistic Researcher Review Board. I'm a white Hispanic male with black hair and light skin, wearing a button-down light pink shirt on a white background with the ARRB logo to the right of me. Yeah, it's great to be here.
Hello, my name is Nancy Burke Hall, and I am a parent of a 16-year-old autistic son. I'm his main caregiver. I am a white woman with long dark hair. I have a blue shirt on, and I am at our home office. Thank you.
So thank you, everyone, for those introductions. We are very excited to have you all here as a part of this presentation. So first, I'm going to tell you a little bit about the agenda. In this video, the Autism Intervention Research Network Neurology Node lead, myself, as well as others, will talk specifically about epilepsy. But before I get to that, actually, let me tell you a little bit about the Autism Intervention Research Network on Physical Health sort of infrastructure, the goals behind it, and then we'll move in more to the neurology node and the goals of this talk. So the ARRB, which is what we call the Autism Intervention Research Network on Physical Health, seeks to establish and maintain an interdisciplinary and multi-center research network for scientific collaboration and infrastructure to increase the life expectancy and quality of life for autistic individuals, particularly for underserved and vulnerable populations. And the purpose of the ARRB is to support innovative life course intervention research that promotes optimal health and well-being of autistic individuals across the lifespan. The principal investigator and lead of the ARRB is Dr. Alice Kuo at UCLA. And as a part of the ARRB, there are several nodes that are established to address the overall mission. Such as genetics, primary care, lifestyle and intervention, and many others. And in this particular one, we'll be focusing on the neurology node. So let me provide you some overview on the neurology node. Well, the focus of the node is really broadly, I'd say, on co-occurring neurologic conditions in autistic individuals, because these are very prevalent. These include things such as seizures, epilepsy, sleep difficulties, motor challenges or delays. And the goal really is to improve identification, awareness, and treatment of common co-occurring neurologic conditions, mainly because many of these, although maybe there is some awareness, oftentimes caregivers and clinicians are not aware on how to identify these best practice parameters on what screening for treatment or in terms of referral to subspecialty providers. And in some cases, there is actually a lack of awareness, particularly in the arena, we'd say, of motor challenges or difficulties. And this is particularly true in many of our autistic adolescents and adults, where some things become less screened for, and it's important to improve awareness over a lifespan. We also seek to develop and test the neurologic, physical health and well-being and developmental outcomes, specifically of motor-based interventions for autistic individuals, particularly given the fact that motor difficulties are often under-recognized and under-screened, and as noted again, often persist early in life throughout adulthood. And we also seek to disseminate information on co-occurring neurologic conditions in autism to the community, healthcare providers, and beyond, and to trainees as well. We do have other specific research priorities within the node and what we'll touch on today, which is understanding the developmental trajectories and adult outcomes, particularly with neurologic conditions, and coordinating neurological care. So today, as a part of this webinar, we'll be focusing specifically on one very common co-occurring neurologic condition in autism, and that's seizures and epilepsy. And our goal today is to focus on that particular area, given the prevalence, given the importance, but then with further talks, further discussions, begin focusing on some of the other areas in neurology that we were talking about. Today, what our learning objectives are to understand what seizures and epilepsy are, and understand how it intersects with autism. We will also be talking about transition of care, particularly in adulthood when it comes to treatment of epilepsy and seizures. And I think from there we can move into our talk. So given that, given this topic, we think it's important that we provide you some background first on epilepsy, as I mentioned in the learning objectives, and also on transition of care, as an opportunity to really frame our panel discussion, which will come at the end, to talk about both personal, provider, and other experiences along this topic. Dee, please, next slide. Thank you very much. So what is epilepsy? We'll talk about that a little bit in the next couple of slides. Well, essentially, it's defined, and we'll go over this again in more detail, as more than one unprovoked seizure in a lifetime. And it's diagnosed by clinical events, visible clinical events, as well as something called an electroencephalogram or an EEG. And here on the left-hand side of this slide, you see a photo of a young boy getting these EEG electrodes placed on his head. They're not invasive. They sit on top of the head in a sticky way or with some adhesive material. And they pick up what you see to the right, which is cortical activity or activity generated by our brain, electrical activity, in an effort to pick up anything that might be atypical. So let's talk about that a little bit more on the next slide and get a little more detailed with the definitions. So a seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, or asynchronous neuronal activity in the brain. So what does that mean? It means that our brain generates many electrical responses and signals to help us do what we do on a daily basis. When that goes awry, when there's too much of that electrical or it's not in the rhythm that it should be, it can lead to something called a seizure, which is this abnormal electrical activity. Epilepsy is when you have two of these seizures, two or more, that are unprovoked and greater than 24 hours apart. So what does unprovoked mean? Well, unprovoked means that it's not in the setting of an illness. One thought is meningitis, for example, which can infect the fluids surrounding the brain and the spinal cord. Others are brain injury, like a traumatic brain injury, getting hit on the head or getting it after a concussion, or a stroke or brain bleed. So an initial sort of inciting event causing this provoked condition. Now, some of those things like a stroke or brain injury then can lead to epilepsy, but we talk about that in that immediate setting, or outside of febrile illness, which is particularly in young ages, 6 months to 6 years of age. So what is an epilepsy syndrome? I put this here because it's important when we think about definitions of seizures and when caregivers or autistic individuals come to us with concerns for seizures and the terminology that we might use. One example of this, for example, is absence seizures, or many people speak about staring spells or petit mal. These are some other terms that they use. Well, an epilepsy syndrome is a complex of signs and symptoms that define a unique epilepsy condition with different etiologies. And that's defined by age of onset, seizure type, and the EEG that I showed you before. So that example of absence seizures is many individuals might come to my clinic, and I should say I'm a child neurologist, so I take care of patients as well as a part of research. And they'll say that, oh, I'm worried that my child has absence seizures. Now, that's a description, the staring spell. But what's important to know is in order to say whether or not your child meets that definition or the individual meets that definition, is getting an EEG where there has to be a specific pattern on the EEG that matches with that, and generally at a certain time or age in their lives. Now, the reason that's important is certain epilepsy syndromes are treated in certain ways with specific medications. So that's why we use some of these definitions to better understand what we may be treating or need to treat. Next slide, please, Dee. So what is the epidemiology of epilepsy and autism? And in a way, why are we talking about it today, really? Well, the occurrence of epilepsy in the general population is thought to be about 1 to 2%, maybe up to 3 to 5% in certain countries. But in autism, that prevalence ranges anywhere from 2 to 60% across several publications and anecdotal information. And it's sort of, I put here in parentheses, a kind of agreed upon by clinicians who treat this, that autistic individuals are about 10 to 20% higher rates of epilepsy compared to the general population. So that's much higher than what you're seeing in the general population here. We also know that that prevalence increases with age. We used to think that wasn't the case, that maybe this would only happen in early childhood, but that's not the case. Seizures can affect even autistic adults for the first time. There is no primary seizure type. So we often talk about, I said in the previous slide, like an absence seizure or staring spell, but it's not that autistic individuals particularly have a higher prevalence of absence or generalized or focal seizures, which is why it's important to be screening for or considering all of these. And I'll mention this briefly here. We won't get into as much detail, but it goes in line with what we're going to touch on the end, our practice parameter, which is, although the prevalence is sort of agreed upon 10 to 20% for epilepsy, abnormal EEGs have been reported in up to 60% of autistic individuals. And there really is no consistent data on whether these abnormalities lead to a higher risk of epilepsy. What I'll say again, I'm touching upon this here because there's a tremendous amount of work and research going into this area, many questions to be had, but it's important to know that an autistic individual could get an EEG, have abnormalities on that EEG, but treatment is not necessarily warranted or recommended, which is why the evaluation from a specialized care provider is important. Next slide, please, Dee. So why the higher risk in autism? I thought this is important. I'm again going to speak to this very broadly, but just important to conceptually understand. This is just a couple of thoughts behind this and just one that I cite, but there's numerous other papers have done work on this. But there's two potential hypotheses that in our brain, the primary inhibitory neurotransmitter or the calming neurotransmitter is GABA. And the thought is that maybe there's a dysregulation of the balance of excitation or inhibition in the brain, either due to defects or differences in GABAergic fibers or GABA receptor function, this inhibitory neurotransmitter function. And we know this because there are several genetic syndromes and variants that are highly related to autism that lead to both epilepsy and high association with autism as well. So, and many of those genetic syndromes have this sort of imbalance there. I should make a note here, and you'll see on the slides, and I should have made a note earlier on, at least for myself in speaking through this, I will refer primarily to identity first language, but there will be times just from the literature that I'm citing that there's both person first and identity first. I do want to note that it is really my goal and aim to be respectful for all, but it is presented in both manners in this talk. The second aspect is sort of that primary epilepsy may impact synaptic plasticity and cortical connectivity, which in turn may predispose a developing brain to cognitive delays and behavioral difficulties as well. Next slide, please, Dee. So moving through, what are some associated factors along with epilepsy in autism? Well, we know from our research that there's a pretty clear link to intellectual disability. There's almost double the rates of epilepsy in autistic children with intellectual disability. And I'll show this on the following slide after going through a few of these points in graphical format. We also know that studies show that there could be a higher rate in females, autistic females. That's not shown in all studies, but there are shown in some. Thus, it's important for clinicians to know. There are higher rates in genetic neurodevelopmental conditions. I mentioned a little bit on the previous slide, but genetic conditions that are also associated with autism, higher rates such as tuberous sclerosis complex or duplication 15q syndrome. And there have been studies, which I'll show later, in terms of higher rates of epilepsy and defined in the studies as associated with greater autism symptomatology severity as defined in the study and poor adaptive function. Next slide, please. This is the graphical format that I explained here in terms of higher rates of epilepsy in autistic individuals with intellectual disability. And you see those with intellectual disability all the way on the left of the graph on the y-axis, having the highest percentages noted on the y-axis of epilepsy. Next slide, please. This I'll just go briefly over this mentioned on the previous slide, but there was a large study that used something called latent class cluster analysis, in which they noted that the cluster of individuals' traits with certain traits with the highest rate of epilepsy were those with earlier diagnosis of autism, greater as they defined as autism severity, and greater gross motor abnormalities. And the following graph will highlight that as well. And here you can see this different cluster analysis, and this paper specifically goes into greater detail about that. Next slide, please, Dee. So what can help determine seizures versus no seizure? Well, we're often, I can speak from the neurology or provider end, asked about daydreaming, zoning out, or as I noted, absence seizures. So what I'll tell you is, first and foremost, as a neurologist, a video speaks 1,000 words to us, sort of like a picture, if it's possible. And we understand many times it may not be, it may be quick, but if you are able to take a video, that's really helpful. Or we'll often ask caregivers or the individual, it's harder maybe for the individual, but to act it out themselves and to show us. We want to know how often it's occurring and for how long. Things that occur for very, very long periods of time, and soon the individual regaining completely themselves is less likely to be a seizure versus maybe those briefer events. The longer the seizure lasts, oftentimes the longer what we call is the post-ictal period, or the period of time to recover from that seizure. And how often? Seizures can definitely occur depending on the seizure type, every 6 months, yearly, but there are certain types of seizures, such as absence seizures, that we don't expect to happen that infrequently, that we might expect them to be more frequent, and having that information can help us figure that out. Confusion during or after the event, or what we call behavioral arrest, can also be helpful to know. Decline in school function or development can be an indication, and more information from the school teachers, therapists, or others that have noted the events is helpful. So I'm often speaking to these individuals to get more information. Next slide, please. I'm going to quickly, actually very quickly touch on this just for time, but it's important for all of our trainees and others to be aware of this. There's a big area of clinical care and study on regression in autism. And the main things to know of is that there are epilepsy syndromes, or what we call epileptic encephalopathies, that are associated with regression in development and behavior, and also abnormal EEGs, and abnormal EEGs that need to be treated. And there's quite a bit of overlap in diagnoses of autism in this regression, or what some people consider maybe regression in some language, at a time when many children are diagnosed with autism, around that 18 months to 2 years to 3 years of age. So it's important to be aware of this, because it's important to refer to a neurologist if you're worried about a significant regression in development. But the one thing we're thinking about on our end is the types of regression, whether language or behavioral, and the age of onset of these things. And we can speak more to this at future talks as well. So why do we treat seizures? Untreated seizures can lead to cognitive decline, developmental delays, behavioral changes, and really poor long-term neurodevelopmental outcome. There is a concern in certain seizure types that if the initial seizures are not treated, then the seizures can worsen, almost a kindling effect, we call it. There are concerns for things such as sudden unexpected death in epilepsy, or SUDEP. It is rare, but it's increased in autistic individuals with epilepsy. So it's important to be considering that in treatment. And in most cases, it is a good prognosis if seizures are treated early. Next slide, please. We'll quickly touch, just because I think it's important to have this information in the slides, on treatment of seizures in autism. Well, the decision, it's important to know, is multifactorial, seizure type, generalized or focused, co-occurring conditions, other behavioral challenges that might exist, and other medications the autistic individual might be on. All of those things we want to keep in mind when we think about medications that can compound one another, not polypharmacy, and trying to really reduce side effects when we can. To the right are just broad sort of things to consider with anti-seizure medications. It's not always the case, and I'll leave that there for the readers to see as well, the viewers. So what is the recommended workup? Well, the American Academy of Neurology and the American Academy of Pediatrics do not recommend a routine EEG for autistic individuals. So not every autistic individual, despite this high prevalence, should get an EEG. It's only recommended if there's an evidence of clinical seizures, a history of developmental regression, as I was speaking to, especially in toddlers and preschoolers, and situations where there's a high index of suspicion that epilepsy could be present. So again, going back to the example of tuberous sclerosis complex, so there's an autistic individual with TSC or tuberous sclerosis. There are much higher rates of epilepsy in this population. So we have a much lower threshold of obtaining the EEG. So why is this the case where it's recommended in that? Well, the idea is doing no harm also, right? If an EEG is not indicated, we don't want to put someone through an EEG if that's not necessary. But also because what I mentioned earlier, that 60%, it can be up to 60% of abnormal EEGs in autistic individuals. And we have run into many scenarios where then these individuals are treated with medications even when that might not be warranted, when there aren't seizures there. Hence the reason why it's important for a specialized care provider to be interpreting these things. Next slide, please, Dee. So with that, I'd like to thank you for your time on this portion of the talk. And I'm going to go ahead and hand it over to Dr. Stobbe, who will be talking about our next topic. Thank you very much.
Thanks, Judah, and thanks everyone for joining today. I'm going to hit on this topic pretty quickly so that we can get to our panel discussion. We've seen more research starting to come in regarding individuals as they age with autism. And we're seeing what we were seeing clinically in practices is that people are at a higher risk for poor health outcomes, especially getting into the adult years. Increased emergency department visits, increased hospitalizations, and increases in aspects of morbidity and mortality. And this is as an adult neurologist, I was seeing this in my practice, and I think that this gets into many of the issues that are of utmost concern to autistic individuals and their family members. And if you go to the next slide, one of the questions that's always on a person and a family's mind is, what's my future look like? And I think when the diagnosis of autism is made in childhood, this is always on the top of parents' minds, for example. And there is research showing this wide variety of outcomes, everything from individuals that have been coined in research literature as what is called an optimal outcome, which is an individual that goes on and lives an independent life, is employed, and does not require significant supports as an adult. This can vary anywhere from 3 to 25% in the literature. We see a similar number of individuals, unfortunately, that have outcomes that require very substantial supports into adulthood, individuals that require 24/7 support for ongoing living. And then the largest bulk are individuals kind of in this middle ground that do require continued supports into adulthood, but at the same time see ongoing progress. If you go to the next slide, Dee. This slide is to try to capture that ongoing progress that we see into the adult years. If you think about specifically developmental progression in social and communication ability, we really see individuals, autistic individuals in the primary and secondary school years as making progress relative to themselves at a younger age, yet falling behind their peers during this age. Now, if you carry that out into the 20s, however, you start to see peers plateauing in their progress, yet autistic individuals continuing to make progress. And this is exciting. This was exciting in my practice as an adult neurologist to be involved in those 20-something years where you see this continued progress occurring. Unfortunately, though, as Rajuda mentioned earlier, if you go to the next slide, we have this concern of regression, this concern of worsening. And epilepsy is one of the things that comes into our mind when we see this, but there are other explanations and often unexplained causes of why an individual might regress in these years when the hope is to continue progressing. Next slide. We did Emily Myers was a researcher here at University of Washington that had access to some data looking at this fact of individuals in their teen years going into adult years. And unfortunately, one of the things that was found in that study was individuals that had a case manager, and this was usually the parent, unfortunately, individuals that had case managers were more likely to continue increasing social connectedness and community participation. And if you go to the next slide, this slide graphs out this group of individuals that were followed from their teen years into their early 20s, showing this especially decline in community participation. And I think this makes sense to all of us that when, we've heard the stories about when the school is no longer available, there's school buses no longer coming, the reduced access to community participation that autistic individuals see in their 20s. We go to the next slide. And so this is an important thing for autistic individuals, parents, and providers to really look at. What are the different factors that influence this outcome? And I have this divided into what I call intrinsic and extrinsic factors. And we're focused in neurology around some of these medical conditions like epilepsy. And as providers, we can have an impact on the long-term outcome by helping to manage these co-occurring conditions. Rajuda showed slides about cognitive ability influencing the likelihood of having epilepsy, and that cognitive ability impacts the long-term outcomes for individuals that are diagnosed with autism. Unfortunately, there are these extrinsic factors like having case management, having access to services and access to providers. These things we know that our population that we work with have so many barriers that often will prevent or reduce access to proper care and services. Next slide. And I end with this slide because I think this is important if you're going into this field, to recognize it's not just, it is super important. Neurology and epilepsy and healthcare is in this kind of lower dark blue part of the cog of the wheel. But if we're really trying to get quality of life, all of these other factors come into play. And this is really important to think about how employment can influence mental health and how physical health can influence mental health, and having access to education and being in a safe environment, how all of these things can ultimately impact what we're driving for all of us, which is optimal quality of life. So I'm gonna end there, and I think we're gonna go to our panel discussion at this point. And I wanted to first call on Nancy as somebody who has experienced from your lived perspective as a caregiver and as a parent of an autistic person with epilepsy. And I wonder if you could kind of highlight for those listening to this, how autism and behaviors related to autism interface with the diagnosis of epilepsy and maybe the challenges that individuals face in accessing proper care.
Well, first of all, the challenge of just having an EEG is huge. As my son has gotten older, we have had a lot of behavioral and aggression issues, which can stand in the way of him physically going into doctor's appointments and so forth. Unfortunately, we even prior to COVID, we did a lot of telehealth visits. what we notice when Riley does have a seizure, because of his cognitive ability, which is very low, and being nonverbal or very little language, we find that he can be, well, after a seizure, which can last anywhere from 1 to 6 minutes, he can be very lethargic and often will sleep for a period of time. And then he can become rather irritable and aggressive, which this can carry over actually into the next day. And when you have a child that has very little understanding of safety and cognitive abilities, as a parent and our caregivers, we are constantly watching him. He needs 24/7 care to begin with, but the seizures of his type of seizure can come about, we notice 6 to 8 weeks go by. Often it's almost like we know one's coming, and usually that is the case. We take data on all his seizures and report those immediately to his neurologist. We also, as far as management of care, he's on 2 different type of medications, and some of the things about these medications, because you are concerned about organs or any type of blood level issues, he does have to have blood work, usually every 6 months. So the medications that he is on can be monitored. And as far as, a parent with a child, not only with autism and the seizures, it's always there in the back of your mind. You just have to be prepared. If you're leaving the house, you always make sure that you have like his seizure recovery medicine, if you have that. And you also make sure that you time the seizures if possible. And after a seizure is done, we monitor with blood pressure, we monitor with pulse and temperature. At any time, if you ever feel the need to call 911, do not hesitate. The first few seizures my son had, yes, we automatically called 911. Then we started to be able to monitor different things. And the neurologist did say to us that it's not necessary every time, but they're there. And if you need to call them, you call them.
Thanks, Nancy. That, as you kind of walk through that, I just think about just how much is placed upon the caregivers and to provide this care. And obviously you do the best you can, and that's all you can always do, right? Is just do your best, the best you can. That's but right. so many challenges with these about looking at different behaviors, and when an individual like your son is non-speaking or minimally verbal, mm-hmm. The challenges that face caregivers on interpreting these signs and symptoms. Zach, I know in your work you come both identified as autistic, and then in your research work, maybe you can kind of share with us some other thoughts to kind of complement what Nancy has said about kind of the interfacing of epilepsy and autism.
Sure. I mean, and so, obviously this is a condition that often starts very early in childhood. And so many people have experienced this for much of their lives. And so they're used to often their parents taking care of it for them. But for those who do have the cognitive ability to eventually manage their own medical conditions, they, will go off and become independent adults, and seizure management and taking care of one's medications and all of that becomes their own responsibilities, especially for those who leave the house, go to college, etc. When they have that ability. Of course, being irresponsible adolescents, as many of us are, that's not always the easiest, and doing things like staying up all night, trigger for seizures, not the greatest, and so on. And so this obviously complicates things for folks, and there's all sorts of issues that this can cause. And, there are other issues in the mix as well. So, can make it even harder when someone has, additional phobias of going to the doctor, or just difficulty really asking for help from, standard social supports. And even things like having difficulty with executive function, taking medicines every day, and so on. So the transition to adult care is also difficult, in just having, going from having your pediatric neurologist who is managing your epilepsy medications to perhaps going to an adult neurologist who you haven't had managing your care for the last 15, 16 years. And making that switch is a whole, mess sometimes. It can be done, but it's certainly, it's whole, a difficult process that many people are not really prepared for. And I think many providers are not really prepared for, as they will not, just simply not have the time or the really ability to take on that case and make sure that they are able to show that they can do this. And also the patient, being used to a pediatric provider who maybe is interfacing with a parent more, doesn't realize that it's their time to take control of their own healthcare when they're moving to the adult provider. So all of these issues can really compound on each other and make it a fairly tricky thing to navigate. Also, driving is always an issue for folks with epilepsy, and laws vary state by state, but needing to be seizure free for a number of months, especially for teens newly want to get their license and things like that, can often be an issue. And so is definitely something you hear about, and you go, I need to stay on my medication, this and that, we need to get my license, and so on. So again, many different issues that do come up. So
thanks, Zach. I think that autistic teens transitioning into adult care, often when you find a pediatric provider that you really love, you don't want to change. It's already hard enough to change at all. And I think that the other point that you kind of hit on that really resonates with me about teaching self-advocacy skills and the importance of trying to teach self-advocacy skills at a younger age. Often we get criticized, both parents and providers get criticized by autistic adults of saying, I wish you would have taught those self-advocacy skills at a younger age. And so I think that's a point we often try to hit home on. Rajuda, maybe you want to take a few minutes to talk about the challenges that face providers to provide this care, and why epilepsy care and neurology care is so challenging and difficult for families and individuals, and then probably transition to closing summaries.
No, certainly. And I so appreciate the things that Nancy and Zach have already commented on, because I think you brought up so many things that naturally just flow into what are these challenges, right? What are the challenges for families? What are the challenges around this treatment? And the reality, as many things, it shouldn't be, right? Given the prevalence and how common it is and the practice parameters that are set on this should be a fundamental thing that's screened for, that individuals have access for. But I think the reality is one challenge is just access to specialized providers that treat autistic individuals and treat epilepsy. And what I'll tell you is I think that's one reason why dissemination of knowledge, I'll speak within neurology, and training of neurologists in neurodevelopmental conditions and in autism is very important. And the example being is there may be one of me or one of Dr. Stobie who treat autistic children, autistic adults, and epilepsy, but there are many more epileptologists or general child neurologists and adult neurologists who have that same ability, but may not feel as comfortable because they haven't worked with autistic individuals as much, or may not be as aware of some of the nuances that we talk about in using certain medications and side effects that we might think about. That doesn't mean we don't use them, but just thinking about these things. And so I think that access is one challenge. And I think one of the ways, other than being able to produce so many more, which would be wonderful, and we need to train neurodevelopmental specialists, is dissemination of this information to other care providers. So primary care providers being aware of the high risk. So if a caregiver, an autistic individual, comes to them and says, there was this funny episode, and I don't think it was just daydreaming or staring off, that the primary care provider, although I'm sure most would prefer, would say, oh, okay, in autism, this prevalence is even higher. Let's refer right away. Let's not wait and just kind of see, where this might go. And second, training our other neurologists about this care and challenges that might be faced, or different ways of communicating, communication skills that are preferred, or different ways of approaching the autistic individual, and getting that information from the individual as well as the caregiver. I think the other is, we do need more resources within our hospitals and facilities to be able to do blood draws, right, on those who might have difficulties with needles in our autism population, or in obtaining EEGs. At UCLA, we work really hard on that in trying to provide an environment in different ways. And, and that often comes down to, unfortunately, but it's reality, but sedation for some of those things. But these are important things in terms of medical care. And then lastly, what I'll just say around those challenges, I think, are what, you all highlighted on, but is now not recognizing the information that we do need to arm our autistic individuals with to be able to self-advocate for their care and from themselves too, particularly when transitioning those who are going to be taking care of their medications on their own, or getting ready for that transition to an adult provider much earlier. So it's not this, you're 18 or 22, I saw you yesterday, guess what, tomorrow you've got to find an adult provider. It's, you're coming upon this age, let's start thinking about what that transition is like. Let's establish a relationship with that person. I can communicate with that person to say, here are some of the things, so can you, and that transition is a lot smoother. So many things to say on that topic, but given the few minutes we've had, I'll touch on those at least. And what I'll say is all areas that I think we're working on here within this group. Individuals are, the ARRB is, but even more work needs to be done.
Thanks, Judah. I wonder if Nancy, I think we have a couple minutes left. Dia, would you say? If anybody has any things that burning comments that they need to get off out of Nancy or Zach. I just, yeah, go ahead, Nancy.
Well, you mentioned the blood draws and how difficult that can be for our kids. I would suggest that people look in their area if there's any mobile phlebotomists. We have had 3 successful blood draws with these folks. They've come to our house. My son was in his environment, so he was comfortable. The anxiety level was much low, and we would have a caregiver, and usually my husband, and we've had the same individual come and do the blood draws. So and in the past, it would take people to hold him down to be able to obtain these labs. So that's a suggestion that I would suggest for parents to maybe look into their areas if they have that available.
Excellent. Thanks, Nancy. Great. Thinking outside the box is one of the things that when you get in doing this work, you start to do. And I think that the importance of making the interface with the medical system less traumatic, I think that plays big into ongoing care into adult years, and the importance of individuals having routine primary care visits so that we can reduce some of these morbidity, mortality numbers that we're seeing. The childhood experiences play a big role in that. And so thank you for that comment. For Judah, I think we're probably ready to.
Okay, sounds good. I wanted to make sure nothing else, but thank you for that great panel discussion. Well, thank you everyone for your time today. As you've seen, we spoke about the ARRB, about the neurology node and the different focus on neurologic co-occurring conditions, and specifically today about epilepsy and seizures. A little background on what those are, the prevalence within autism, important considerations for screening, and then of course, important considerations and information for families on navigating that, challenges that we faced, and potentially ways in which we could address those. So certainly more good work to be done. And we look forward to speaking to you all in the future about other topics within neurology. I want to thank everyone who was a part of this call today, Nancy, Dee, Zach, and Gary. And next, what you'll find on the slides are all of our contact information. Please feel free to connect with us if any questions arise. And also want to share with you some of our social media handles for ARRB. Particularly what I'll say is a lot of these handles on the website do list out other webinars that are happening within the ARRB and other research items as well, and opportunities, including scholars opportunities. Thank you very much for your time.